Welcome to our video on abdominal hernias. Let's begin. Here are some topics that we're going to discuss in this lecture. Let's start with a general overview. A hernia is a protrusion of tissue through the abdominal wall. This likely occurs when the abdominal wall loses its mechanical integrity. It is usually present in areas of discontinuity of the abdominal wall, such as the groin, umbilicus, or incisional sites. The hernias could be acquired or congenital in nature. Let's move forward, discussing the anatomy of the inguinal canal in this image. The inguinal canal is located parallel and superior to the inguinal ligament. It has two openings, the internal inguinal ring, found above the middle of the inguinal ligament, and the external inguinal ring. The end of the inguinal canal is located superior to the pubic tubercle. The external inguinal ring opening is within a zone of weakness known as the Hasselbalch triangle. Hasselbalch triangle is limited medially by the rectus abdominis muscle, laterally by the inferior epigastric vessels, and inferiorly by the inguinal ligament. Some of the inguinal canal contents are ilioinguinal nerve, spermatic cord in males, and the round ligament of the uterus in females. With that brief overview, we can continue with inguinal hernias. We will discuss the introduction, etiology, pathophysiology, risk factors, clinical presentation, diagnosis and management of the inguinal hernias. Let's start with the introduction. Inguinal hernias are divided into indirect and direct based on their anatomical location. Indirect hernias are the most common type of abdominal hernia. They are commonly found in children. This type of hernia protrudes laterally to the inferior epigastric vessels. Then goes direct hernia, which protrudes medial to the inferior epigastric vessels through the Hasselbalch triangle. Let's talk about the etiology. Most of the time, indirect hernia is caused by a congenital defect. It results from the persistence of the processus vaginalis. On the other hand, direct hernia is typically an acquired condition. It is caused by a focal weakness in the transversalis fascia. This image will help us cover the pathophysiology of indirect inguinal hernia. It results from the incomplete obliteration of the processus vaginalis. Processus vaginalis is an outpouching of the parietal peritoneum through which the testes migrate through the scrotum during embryological development. Usually, before birth, the layers of the processus vaginalis fuse and it obliterates. But a failure in this process can precipitate an indirect hernia. The contents protrude into the inguinal canal, lateral to the inferior epigastric blood vessels. They protrude through the internal inguinal ring along with the spermatic cord in males or the round ligament in females, then emerge at the external inguinal ring, extending down into the scrotum or labia. Now we will discuss the pathophysiology of direct inguinal hernia with the help of this image. Most of the time, it is an acquired defect due to the focal weakening of the transversalis fascia. It is located medial to the inferior epigastric blood vessels and lateral to the rectus abdominis. This means that the direct hernia protrudes directly within the Hasselbalch triangle. It then goes through the superficial external ring. Note that the contents of direct hernia do not protrude through the internal inguinal ring as opposed to indirect hernia. Next, we are going to continue with the risk factors of direct hernia. They are mainly those conditions that increase the weakness of abdominal wall or increase the intra-abdominal pressure. Conditions such as being an older man, having a family history of hernias, smoking, chronic cough, heavy lifting, and collagen vascular disease are the most important risk factors for developing a direct hernia. Now let's move forward with the clinical presentation. Let's start with indirect hernia. The clinical presentation of indirect hernia has a wide range of variations. It can be asymptomatic. However, it can present with an intermittent mass that can be noted with the increase of abdominal pressure. For example, when a baby cries, the mass can be noted in the groin, and when the baby calms down and is supine, the mass decreases in size. Now let's continue with the clinical presentation of direct hernia. It can be asymptomatic as well, or it can present as a bulge in the groin. Due to this bulge, the patient can feel some discomfort. Here we're going to talk about the clinical presentation of the complications of direct and indirect hernias. First, let's start with incarceration. Incarceration means that the hernia cannot be reduced back into the abdomen or pelvis. The bowel gets trapped in the hernia sac. Symptoms of mechanical obstruction like pain, nausea, vomiting, and constipation can be evident. On the other hand, strangulation implies a compromise of the bowel blood supply due to constriction of hernial contents. The patient presents with a painful red and swollen mass in the groin. On the physical examination of inguinal hernias, different findings can be encountered. Let's discuss them. First of all, if the hernia is asymptomatic, it is not usually present on the physical examination. However, the hernia can be reducible and presents as a mass that can be palpated and is reducible with pressure. Also, it is not tender to palpation. Next, we encounter an incarcerated mass, where the hernial contents cannot be pushed back into the abdominal cavity. This may present with signs of intestinal obstruction, such as abdominal distension. Also, it is important to remark that the overlying skin remains intact. However, the reduced venous blood flow leads to swelling of the hernial contents. As the edema grows, the arterial blood flow can become compromised, leading to strangulation of the hernia. Thus, a patient who has a strangulated hernia presents with signs of sepsis, such as tachypnea and tachycardia, as well as redness of the skin. This image shows the complications of inguinal hernias. On the leftmost side, we have an uncomplicated hernia. When the mass can be easily pushed back through the abdominal wall, it is known as a reducible hernia. The following two illustrations show the complications of an inguinal hernia. The first one, in the middle image, is an incarcerated hernia, which means that the mass is irreducible, but the skin over the hernia does not have any changes and the blood supply is adequate. Lastly, we have a strangulated hernia, an irreducible mass with the signs of ischemia or necrosis due to loss of blood supply. Let's continue with the workup of inguinal hernias. Most of the workups are clinical. It is mainly diagnosed with patient's history and the physical examination. In fact, the physical examination can help us differentiate the indirect hernia from the direct one. An indirect hernia can be detected by the palpation of the groin when the mass appears coming from the superolateral to inferomedial side and touching the distal fingertip. However, a direct hernia can be diagnosed when the mass comes from the deep to superficial and touches the finger pad. This is clearly illustrated on the next slide. Before I go any further, I'd like to mention that this image was contributed by Amboss. Thanks for our partnership with Amboss. I can highlight several important features of uncomplicated hernias. In this image, we will dive deeper and recognize some of the maneuvers of the physical examination of the uncomplicated hernias. First, we may ask the patient to perform a Valsalva maneuver or to cough. Meanwhile, we observe the inguinal region looking for an expansible mass and its path. Then, we proceed to palpate the inguinal canal. To do this, we place a fingertip into the scrotal sac and move upward into the inguinal canal, as shown in the image. If a bulging mass comes from a superlateral to inferomedial and directly touches the fingertip, it is most likely an indirect hernia. But if a mass comes from deep to superficial and touches the finger pad, then a direct hernia is more likely. Let's try a question. A 4-year-old boy is brought to the physician due to protruding mass in his left groin covered with skin. The bulge is displaced downward when the patient cries. The physician inverts the scrotal sac with his index finger and asks the patient to cough. The bulge is felt at the tip of the physician's finger during cough. What is the most likely pathophysiology of this patient's condition? This patient presents with a protruding mass in the left groin covered with skin. The bulge is displaced downward when the patient cries. These findings are consistent with the diagnosis of a non-incarcerated inguinal hernia. Now we need to determine whether this is an indirect or direct inguinal hernia. The physician inverts the scrotal sac with his index finger and asks the patient to cough. The bulge is felt at the tip of the physician's finger during cough. This finding is consistent with an indirect inguinal hernia because it travels through both the internal and external inguinal rings. That is why the bulge is felt at the tip of an examiner's finger rather than on the side. The indirect inguinal hernia is caused by failure of processus vaginalis to obliterate. Therefore, part of the intestine can go through the patent processus vaginalis all the way with the spermatic cord. Let's continue with the diagnosis of inguinal hernias, discussing the role of imaging. Imaging can be of help if the diagnosis is unclear, if there is an occult or recurrent inguinal hernia, or in the preoperative setting. The best initial imaging test is ultrasound. However, CT with IV contrast is indicated if the ultrasound findings are normal, but there is high suspicion of inguinal hernia. CT with IV contrast can also be helpful to assess the hernial contents blood flow. Please note that if the patient has a known hernia with signs and symptoms of incarceration or strangulation, imaging is not needed prior to surgical repair. Now, we are going to discuss the management of the complicated and uncomplicated hernias separately. Firstly, uncomplicated hernia, as we already mentioned, is most of the time asymptomatic or a reducible mass. It can be managed with an elective surgical repair. However, surgery must always be recommended to avoid future complications. Also, if the patient doesn't want a surgical repair, he must be informed about the signs and symptoms of incarceration and strangulation to be aware of any complications. When the hernia is complicated, surgical repair is always indicated. In the case of an incarcerated hernia, a manual reduction of the inguinal hernia should first be attempted. If the reduction is successful, we ought to consider surgical repair during the same admission to avoid complications. If the reduction is unsuccessful, surgical repair should be prompt. In the case of strangulated hernia, an urgent surgical repair must always be done. In the upcoming slide, we're going to dive deeply into the surgical procedures. Among the surgical procedures, the first one is hernioplasty. In this procedure, the hernial defect is repaired with a synthetic mesh placement. This is usually preferred over the herniorrhaphy, hence tagged as gold standard management. Hernioplasty can be performed through an open or laparoscopic approach, and the decision is based on the complications. An open surgery must be performed if there are any complications or if the patient has other contraindications to laparoscopic surgery, such as a high risk of general anesthesia. However, recurrence is a common complication of these procedures. So, if the hernia is bilateral or recurrent after an open repair, laparoscopic surgery is the best option. If hernioplasty cannot be performed or the risk of infection is high, the surgeon can do a herniorrhaphy, which is an open surgical repair of a hernial defect using autologous tissue. This procedure has a greater risk of recurrence. During the surgical repair of the inguinal hernias, complications such as nerve injuries are common. The nerves that can be injured are genital branch of genitofemoral, ilioinguinal, iliohypogastric, and lateral femoral cutaneous. First, an injury to the genital branch of the genitofemoral nerve causes loss of cremasteric reflex in men and loss of sensation in the scrotum or labia majora. Second, an injury to the ilioinguinal nerve causes loss of sensation of the skin along the ilioinguinal ligament, medial groin, labia majora, scrotum, and inner thigh. Symptoms of iliohypogastric nerve injury include hypoesthesia of the suprapubic region. And finally, the injury of the lateral femoral cutaneous nerve, also known as meralgia paresthetica, is characterized by loss of sensation in the lateral side of the thigh. Let's try a question. A 63-year-old man presents to the emergency department with abdominal pain that started 2 hours ago. The physical exam is significant for a tender erythematous and edematous inguinal mass. He noticed this protrusion after lifting the heavy boxes at work and has never been painful before. What is the best next step in management of this patient? This patient with abdominal pain has a tender erythematous and edematous inguinal mass. This presentation is consistent with incarcerated inguinal hernia. Considering his age and appearance of hernia after lifting the heavy boxes, he likely has a direct inguinal hernia. The next best step in the management of an incarcerated hernia is an urgent surgical repair to avoid necrosis, peritonitis, and sepsis. Now, we are going to continue our lecture discussing femoral hernia. We will cover the definition, pathophysiology, risk factors, clinical presentation, diagnosis, and management of femoral hernia. Let's continue with definition. Femoral hernia is a protrusion of tissue through the femoral ring. The femoral ring is located inferior to the inguinal ligament and medial to the femoral vessels. It is more common in women. Also, it is more susceptible to strangulation because it has a narrow neck. This image shows the site of protrusion of the femoral hernia. A femoral hernia appears below the inguinal ligament through the femoral ring, whereas inguinal hernia appears above the inguinal ligament. On this image, we can explain it better. The femoral ring is placed lateral to the lacunar or gimbrunate ligament, medial to the femoral vein. The protrusion through this small space makes the femoral hernia more susceptible to incarceration and strangulation. Let's discuss risk factors. Femoral hernias are common in females between 40 and 70 years of age, especially with a past medical history of multiple pregnancies. Also, increased intra-abdominal pressure such as constipation, obesity, or chronic cough can precipitate a femoral hernia. Let's try a question. A 57-year-old woman comes to the physician reporting a protruding mass in her right groin. Her BMI is 34. The physical exam reveals the protruding mass below the right inguinal ligament. The mass is displaced downward when the patient coughs, and it disappears when the patient lies down. What are the modifiable risk factors for this patient's condition? The woman presents with the protruding mass in her right groin. The physical exam reveals the protruding mass below the right inguinal ligament. The mass is displaced downward when the patient coughs, and it disappears when the patient lies down. All these clues point to the diagnosis of a non-incarcerated femoral hernia. The modifiable risk factors for femoral hernia include obesity, constipation, and the smoking-related lung diseases inducing cough. Now, let's review the clinical presentation of the femoral hernias. They can be classified as uncomplicated and complicated ones. First, let's mention that femoral hernia can be an occult hernia. An occult hernia is a small hernia that is difficult to diagnose clinically. However, it can present as swelling in the groin that enlarges with Valsalva maneuver or coughing. Complications of femoral hernias include incarceration and strangulation. Incarceration presents as an irreducible mass without skin changes. And finally, a strangulated hernia presents with tenderness and discoloration over the mass. Signs of sepsis, such as increased or decreased temperature, leukocytosis, tachypnea, and tachycardia, as well as symptoms and signs of bowel obstruction like abdominal distension and high-pitched bowel sound. The diagnosis of femoral hernia is primarily clinical. On the physical examination, we may palpate a bulge below the inguinal ligament that enlarges with coughing or Valsalva maneuver. However, most of them are asymptomatic and not usually present on the physical examination. So if the physical examination is inconclusive and the suspicion is high, ultrasound is indicated. This image is going to help us recognize some important anatomical references. A femoral hernia is difficult to palpate, especially in patients with abundant adipose panicle. First, we should evaluate the inguinal canal and inguinal floor, which is the inguinal ligament. Then we can ask the patient to perform a Valsalva maneuver. A bulge is then felt below the inguinal ligament, between the femoral vessels and the pubic tubercle. This finding is highly suggestive of a femoral hernia. Now let's move on to the management of femoral hernia. If the patient is asymptomatic or presents with an uncomplicated hernia, we must recommend an elective surgical repair and then explain the possible risk of complications. Once the patient has decided to undergo surgical repair, a laparoscopic approach is preferred in these patients unless there are contraindications. Some contraindications to laparoscopic surgery include incarceration, infection, or ascites. If the hernia is complicated with incarceration or strangulation, then an urgent open surgical repair is indicated. This slide briefly reviews the most important highlights. First, we have the direct hernia, which leaves the abdomen through a transversalis fascia focal weakness. It passes through the Hesselbach triangle, medial to inferior epigastric vessels. Some well-known risk factors are old age, family history of hernias, smoking, chronic cough, collagen vascular disease, and in people who do heavy weightlifting. Then we have the indirect hernia, which most of the time is a congenital defect caused by the persistence of the processus vaginalis. It goes through the deep inguinal ring lateral to the inferior epigastric vessels. Finally, we have a femoral hernia that protrudes below the inguinal ligament and lateral to the pubic tubercle through the femoral ring. It most commonly is seen in females with a history of multiple pregnancies. Let's end the lecture with a question. A 75-year-old man presents to the physician due to protruding mass in his left groin. He first noticed the mass after he was placing the furniture in his new home. He has been smoking 2 packs of cigarettes per day for the last 50 years. His vital signs include a temperature of 36 degrees Celsius, blood pressure of 145/80, heart rate of 75, and a respiratory rate of 15. The physical exam reveals that the bulge is displaced downward when the patient coughs and disappears when the patient lies down. The physician inverts the scrotal sac with his index finger and asks the patient to cough. The bulge is felt at the side of the physician's finger during cough. Which of the following is the most likely underlying cause of the patient's physical exam findings? A. Weakness of transversalis fascia. B. Persistence of processus vaginalis. C. Pleuroperitoneal membrane defect. D. Phrenoesophageal membrane laxity. This patient presents with a protruding mass in his left groin. He first noticed the mass after he was placing the furniture in his new home. The physical exam reveals the bulge that is displaced downward when the patient coughs and disappears when the patient lies down. All these findings suggest the diagnosis of an inguinal hernia. The physician inverts the scrotal sac with his left index finger and asks the patient to cough. The bulge is felt at the side of the physician's finger during cough. This clue indicates that the patient most likely has a direct inguinal hernia because direct inguinal hernia travels from Hesselbach triangle to the external inguinal ring. This is why the bulge is felt at the side of the examiner's finger. The underlying cause of the direct inguinal hernia is weakness of the transversalis fascia. Therefore, the correct answer is A. Here's a slide reminding us of the underlying causes of indirect and direct inguinal hernia. Let's discuss why the other options are incorrect. Option B, persistence of processus vaginalis, causes an indirect rather than direct inguinal hernia. Option C, pleuroperitoneal membrane defect, causes congenital diaphragmatic hernia. Finally, option D, phrenoesophageal membrane laxity, is the cause of the sliding hiatal hernia. And that concludes our lecture on hernias.